Good evening, everyone. I would like to welcome my dear friend and colleague, Dr. Aparna, today, who is Clinical Director for Neonatology at KIMS Cuddles Gachibowli, one of the uh, most knowledgeable, humble, and a very good person. I'm sure she is helping a lot in her series of one that is online medical education in neonatology. And today, ma'am has taken out time to discuss and make us understand ECGs specifically in neonatology. Without wasting much time, ma'am, please you can start your session. Thank you for taking out time, ma'am.
Thank you so much, Dr. Nitin, for your very kind introduction, as well as giving this opportunity, this platform to be sort of interacting with your team. Um, so, as Dr. Nitin has already kind of given you a brief introduction, we are going to discuss about the specifically the clinical aspects of interpretation of ECG, and we will try to probably do this with the specific relevance in newborns. There might be a little bit of overlap in some slides because it looks like you have been oriented with some of the aspects we may also be touching upon today. So, common situations, when ECG comes to our rescue, we all generally are little kind of probably scared about interpreting ECG. We quite often resort to the use of more advanced techniques, like now functional echocardiography is coming in a big way. But ECG is something that still kind of scares us a little bit because we often struggle to interpret ECG. But there are a lot of situations, both in newborns and in pediatric age group, where ECG becomes very handy. Say, for example, in an infant with tachycardia. So you want to know whether this is sinus tachycardia versus a tachyarrhythmia. Or in a bigger child or an adult with a syncopal attack, where you want to rule out a bradycardia, a sick sinus syndrome. In heart failure or in suspected cardiomyopathy, there are not many ECG changes that help us in our diagnosis. And of course, ECG in specific structural heart diseases, where the axis chamber hypertrophy helps us to get a little closer to the diagnosis. For example, the presence of left axis deviation in a newborn with cyanosis may point towards the diagnosis of tricuspid atresia. And as Dr. Nitin just alluded to, in the detection as well as the management of dyselectrolytemia. For example, the ECG changes of hyperkalemia often help us in guiding the management of hyperkalemia. For example, should you use calcium? Do you have to straight away use insulin lowering agents, etc.? So, first and foremost, it is important that we distinguish normal from abnormal ECG. And before we go on to the specific aspects of neonatal ECG, we all know the genesis of the heart rhythm. The sinus node, which is also known as the sinoatrial node, the SA node, is located in the right atrium in the upper right hand aspect. And this is called as the natural pacemaker of the heart. And from here, the impulse travels to the atrioventricular node or the AV node, which results in a kind of physiological slowing of the heart rate. From here, the rhythm further travels down through the bundle of His, which divides into the right and the left branch, and through the Purkinje fibers, the electrical rhythm is transmitted into the rest of the ventricular muscle. So the ECG waveform, which constitutes of the following waves. The P wave corresponds to the atrial depolarization. The QRS wave corresponds to the ventricular depolarization, and T wave corresponds to ventricular repolarization. So we have the P wave, the QRS wave, each of which represents atrial and ventricular depolarization or the action potential in the atria and the ventricular respectively. And the T wave represents ventricular repolarization. Now, when we look at the leads, I think you have already seen about the frontal and the limb leads. So the frontal leads provide us information about the left to right and the superior to inferior forces, whereas the precordial leads, V1 to V6 leads, they provide information about the horizontal as well as the AP, anteroposterior forces. I'm sure you have also looked at this. So this is the typical placement of the leads, the right arm, the left arm, and the left leg. Now, the leads 1, 2, and 3 are headed in the following directions. So each of these is represented by a vector. So when we talk about a vector, you have a definite magnitude as well as a direction. So when you talk about lead 1, you can see that the direction of the vector, which is towards the positive mark, is from the right arm towards the left arm. Likewise, lead 2 has the direction headed from the right arm towards the left leg. Whereas the lead 3 is a vector which is originating from the left arm towards the left leg. So it has its negative direction in the left arm and the positive direction is towards the left leg. We also have the AVR, AVL, and the AVF leads, which are again vectors. And you can see that the direction is pointed towards the side as indicated in the name of the lead. So AVF is, for example, directed towards the foot. AVL is directed towards the left arm. So this is how it looks with when we look at the frontal and the limb leads, which help us to give us both the left, right, as well as the up, down orientation of the heart. So the typical axis in an adult would be something around 60 degrees, and we will see how this changes across the age. Usually in the neonatal heart, the heart tends to be more horizontally placed. So when we are talking about the axis of the heart, we talk about again the directional vector. For example, the regular axis usually corresponds to lead 2, which in turn corresponds to an angle of around 60 degrees. The precordial leads or the horizontal plane leads, as indicated by the numbers V1 to V6, on the other hand, give us some degree of anteroposterior orientation. So we have the V1 to V6 leads as indicated in the picture here. So if you were to imagine the chest, the ribs in particular, the V1 is oriented in the fourth intercostal space just to the right of the sternum, whereas V2 is located in the fourth intercostal space just towards the left of the sternum. As we move further towards the left side, we have the V3, V4, V5, and V6 leads, as you can see. V3 is between V2 and V4, and V4, 5, and 6 all are situated in the fifth intercostal space at the mid-clavicular, the anterior axillary, and the mid-axillary line, respectively. We also have V3R and V4R leads, which correspond to V3 and V4, but are situated on the right side of the chest. So the utility of these leads is to also provide anteroposterior orientation in addition to the left, right, and the top-down orientation provided by the limb leads. Now, we have discussed, I think, about the speed of the ECG recording. Usually, when we look at the standard speed, which is 25 millimeters per second, we kind of refer to the small squares here. So in 1 second, we effectively have 25 small squares. And if you see, each of the large squares in turn has 5 small squares. So each large square again is a square of 5 small squares horizontally and 5 small squares vertically. So one small box is effectively equal to 0.04 second. And one large box, which has 5 small squares, corresponds to 0.2 second. So 5 large squares or 25 small squares would correspond to 1 second. And this is the standard ECG speed. So this is something that will become handy later when we calculate the heart rate using the ECG. Whereas on the vertical axis, one large box of 5 small boxes corresponds to a voltage of 0.5 millivolt. So 5 small squares correspond to 0.5 millivolt, and hence one small square corresponds to 0.1 millivolt. So in other words, each small square in the ECG strip in the horizontal axis corresponds to 0.04 second, whereas in the vertical axis, it corresponds to 0.1 millivolt. Now, how this helps us in the calculation of the heart rate is something that we will see later. So you can see very nicely the waves of the ECG represented in this diagram. You have the P wave, followed by the negative deflection in the form of Q, a positive deflection in the form of R and S. QRS representing the ventricular depolarization, followed by T wave, which represents ventricular repolarization. We generally do not find a U wave, but you may find it in some electrolyte disturbances like hypokalemia. So we have so far discussed the typical orientation of the ECG waveform, and we have also discussed briefly about the speed of ECG recording and what one small square in the horizontal and the vertical axis represents. So the following are the pacemakers of the heart. We already saw that the SA node is a dominant pacemaker, the natural pacemaker of the heart, which has a dominant pacemaker activity. It has a high intrinsic rate, and in adults, it corresponds to 60 to 100 beats per minute. Now, in most newborns, the natural intrinsic rate is anything between 100 to 160 beats per minute. The AV node, which is a backup pacemaker, has a slightly lower intrinsic rate of 40 to 60 beats per minute, whereas ventricular cells, which are the next level backup pacemaker, have a much lower intrinsic rate, which is just 20 to 45 beats per minute, which is why idioventricular rhythm in cases of heart block is usually quite low and corresponds to around 40-45 beats per minute. So when we look at an ECG, we know that there are so many things that come to our mind, and we will try to discuss some of them. So how do we systematically approach interpretation of ECG? So we start with calculating the rate followed by the rhythm, whether it's regular, irregular. The calculation of axis, I'll probably leave for the day because this has been already discussed. Then we try and interpret some of the intervals. The PR interval, QRS, and QTC interval are of significance to us. We shall be discussing and interpreting the P wave, abnormalities in its size and shape, R wave progression, as well as changes in the Q wave, as well as STT segment changes, which help us to diagnose some conditions like myocarditis. So first step is to calculate the rate. Now heart rate can be calculated either by dividing 1500 by the number of small squares between two adjacent R waves, or by dividing 300 by the number of large squares between two adjacent R waves. So essentially you look at the number of squares between R and R waves of the two adjacent heart ECG waves, and either we take the number of small squares between the two R waves, divide 1500 by the number of small squares. So for example, if we are finding that there are 20 small squares between two adjacent R waves, then we divide 1500 divided by 20, and this is going to be 75. On the other hand, if you were to divide by the number of large boxes, we know that if there were 20 small boxes, the number of large boxes would have been 4. So 300 divided by the number of large boxes, which is 300 by 4, also gives us 75. So we can use either of these techniques to calculate the heart rate. So let us look at an example. So here you have the gap between two adjacent R waves as indicated by the two adjacent down pointing arrows, blue arrows. So there are roughly two large squares between the two adjacent R waves, and hence the rate is 300 divided by 2, which is 150. Whereas in the adjacent sort of strip, it looks like the gap between the R waves has slightly widened and is now becoming closer to three large squares, three large boxes, and hence the rate based on this particular gap, that is the penultimate gap between the two adjacent R waves, is 300 divided by 3, and this comes to 100. So when RR interval is variable, obviously the heart rate itself is variable, and that's why we are getting a variable RR interval. But this can lead to difficulty in calculating the heart rate. And in these cases, we have an alternative technique called as the 6-second method, wherein we record a ECG strip for 6 seconds time duration, count the number of QRS boxes, and multiply this by 10. So this is very similar to counting the heart rate during neonatal resuscitation, wherein you count the heartbeat of the newborn, or you sometimes we look at the umbilical pulsation, or we just count heart rate using auscultation for 6 seconds, and then what do? We multiply by 10. So if, for example, in a 6-second strip, we see 8 QRS complexes, what is the heart rate? It is 8 multiplied by 10, which is 80 beats per minute. So this is another simple way of calculating heart rate when the gap between adjacent RR waves, R intervals, is very variable. The next sort of step in ECG interpretation is to determine the regularity of ECG. So are the heartbeats regular? Now, again, this is assessed by looking at the RR distances. So if RR interval is equal, or R and R is equidistant, then usually the rhythm is regular. But sometimes you may have few regular RR intervals and few irregular RR intervals, and this can lead to confusion in the interpretation of rhythm. So the next step here in interpretation of ECG is to assess the P wave. So does the P wave look uniform in all the waves? Does the P wave appear to be regular in rate? And is there only one P wave before each QRS? Or are you seeing multiple P waves before the QRS waves? So normally with P waves, we say only the P wave with one P for every QRS. So it's normal to have a 1:1 relationship between the P and the QRS. Now, if you find, on the other hand, that there are multiple P waves, so for example, if the newborn has two P waves before every QRS complex, then the baby could be having a 2:1 heart block. The next step is to determine the PR interval. So PR interval is the difference, or is the distance between the initiation of the P wave to the end of the R wave. Now, usually the PR interval is something between 0.12 to a maximum of 0.2 seconds. QRS duration is again the duration that encompasses the QRS wave, and this usually varies between 1 to 3 boxes, which is small boxes, so 0.08 to a maximum of 0.12 seconds. So this is the summary of the rhythm, the rate, regularity, P waves, PR interval, and QRS duration. Of course, the rate in a normal newborn is going to be much higher. It is going to be 100 to 160 beats per minute. So in sinus rhythm, every QRS complex is preceded by a P wave. PR interval is normal, and the P wave axis is also normal. So P wave axis is considered to be normal if P wave is upright in both lead 1 as well as in AVF. Now, when it comes to the ventricular axis determination, I think this has been already discussed. There are multiple approaches to calculate the ventricular axis. So we can locate the quadrant of in which the ventricular axis lies by using the lead 1 and lead AVF. So for example, lead 1 and lead AVF, if both of these are positive, then it is considered to be normal axis. Whereas if lead 1 is negative and lead AVF is positive, which means both of them are pointing towards each other, then this is seen with right axis deviation. Whereas lead 1 positive and AVF negative, which is both of them are pointing away from each other, this could happen with left axis deviation. Both waves negative can happen with extreme or superior axis deviation. So this is a technique using the lead 1 and AVF for the calculation of axis. Now, we could find a lead with the equiphasic QRS complex, which may correspond to the overall axis of the heart. This is another way. And the third technique is a graphical technique, wherein we can use any two of the 6 limb leads, and we actually find the net amplitude of the two chosen leads. For example, if this is one baby's lead 1 and AVF chosen here, the net lead 1 amplitude is, we have 10 positive squares and 1 negative square in the QRS. So 1.0 minus zero point 0.1, which is 0.9 positive. And when you look at AVF, there is positive deflection of 0.2 and negative of minus 2.7, and hence the net amplitude is minus 2.5. So you take a graph and plot the corresponding sort of amplitude in the corresponding direction. So in lead 1, 0.9, and in AVF, it is minus 2.5. So, and then we drop a perpendicular from both these points, and wherever they intersect, we connect the midline of this graph to this point of its intersection. The axis corresponds to around 70 degrees. So this is another way of calculating the axis. So we basically calculate the net amplitude in any of the two limb leads, and we kind of plot this net amplitude on a graph that represents only these two axes, and we find out where the perpendiculars drawn to the two axes meet, and the point connecting this point to the point 0 will give us the axis. Of course, the other standard way which is often used is to look at the orientation of only lead 1 and AVF. Now, if both of them are positive, like in this particular ECG, then this is usually indicative of a normal axis. And if the lead 1 as well as AVF is facing each other, this is usually seen with right axis deviation, which we often see in newborn babies. So this is a rhythm where you have lead 1 is net positive and AVF is net negative. So both lead 1 and AVF are pointing against each other. So what do you think is the axis? So this is left axis deviation. Whereas if both have a net negative deflection, it is usually indicative of a superior axis deviation. So here lead 1 is negative and AVF is positive. This is again indicative of right axis deviation. Now, axis in the normal newborn is usually plus 30 to plus 180 degrees. So it's usually situated more towards the right side. And in 1 to 3 month old infants, you see an axis of plus 120 to plus 10 to plus 125. And more than 3-year children, it would be plus 20 to plus 120. Coming to the P wave axis. So P wave axis simply represents the direction of the atrial depolarization vector. Normally, the axis is plus 0 to plus 90 at any age. And if we find that the abnormal right deviation of P wave axis is there to more than plus 90 degrees, it is seen with atrial inversion or dextrocardia. Whereas a superiorly oriented P wave axis is seen with AV junctional or nodal retrograde conduction or low ectopic atrial pacemaker. So what is to be remembered is the P wave axis is usually between 0 to 90 degrees. Fairly, it corresponds to the QRS axis. The T wave axis, on the other hand, represents ventricular repolarization with the mean axis being plus 25 degrees. Some intervals and segments. So we'll discuss now about PR interval, QRS duration, and the QT interval. So PR interval, as we already discussed, is measured from the beginning of the P wave to the beginning of the QRS complex. So this normally varies between 0.12 to 0.20 or 3 to 5 small boxes. It varies from 0.1 to 1, 0.1 at 1 month of age to 0.16 at around 12 to 16 years of age. Now, what is the significance of knowing the normal PR interval? This is because we see short PR interval in WPW syndrome. This I think has already again been discussed. So this leads to aberrant conduction, short PR interval, and we may be able to see the delta wave or slurring in the QRS complex. It may be also seen with glycogen storage disorders like Pompey's disease. Whereas prolonged PR interval is often seen with myocarditis, either of rheumatic, viral, or diphtheric origin, or with some drug toxicity like digitalis, quinidine, and also with hyperkalemia. So these are all conditions, or these are drugs which prolong the conduction across the AV node. Variable PR interval can be seen with Mobitz type 1 second degree heart block. The QRS duration, wherein the normal width of the QRS is less than 0.09 second in all the leads, but it varies with the age. So these are the upper limits of the QRS duration. In general, in children less than 3 years, the QRS duration is less than 0.07 second, which is not more than 2 small squares. So QRS duration can be prolonged in ventricular conduction disturbances, which can be seen with bundle branch blocks and in WPW syndrome. So in WPW syndrome, we see both short PR interval and a prolonged QRS interval. It may also be indicative of arrhythmia of ventricular origin. So normal QRS, it points out towards a supraventricular tachycardia, whereas abnormal or long QRS is usually indicative of ventricular tachycardia. So here we have an ECG strip here. The QRS interval is roughly corresponding to one small square. Hence, the QRS duration is 0.04 second, which is normal. So as we already discussed, a QRS duration of more than 0.09 seconds is taken as abnormal irrespective of the age group. Now, we have discussed PR interval and QRS duration. The next interval we'll be discussing is the QT interval. So normal values in QT interval vary with the heart rate. They vary based on the RR interval, and hence we calculate something called as corrected QT interval. So RR interval should extend from the R wave in the QRS complex in which you are measuring the QT to the preceding R wave. So the QT interval represents the distance between the beginning of the Q wave to the completion of the T wave. Now, how do we correct this QT interval in order to account for variations in the heart rate? We divide QT by the square root of RR interval. So if you do this calculation, it is called as QTC, and the normal QTC is between 0.42 to 0.44 second. So in this particular ECG, you can see that this is the QT interval from the beginning of the Q to the end of T. So this distance is calculated. For example, let us assume this is 8 small squares. So then the QT interval is 8 into 0.04, which is 0.32. This is to be divided by the square root of the RR interval. So let us again assume that the RR interval is around 10 small squares. So 10 into 0.04, which is 0.4. So square root of this is calculated. And if you divide 0.32 divided by the square root of 0.4, you get the QT interval, QTC interval. And the normal QTC is 0.42 to 0.44 seconds. Now, why this QTC interval is so important is because prolonged QTC interval can be seen with hypocalcemia, myocarditis. It can be also seen with diffuse myocardial disease. And there are some specific syndromes where we see long QT syndrome along with some other syndromic associations like Jarvell-Lange-Neal syndrome, Romano-Ward syndrome, and drugs like quinidine and procainamide. Whereas short QTC interval can be seen with hypercalcemia as well as with digitalis. Now, P wave, again we discussed this. P wave, the normal amplitude usually is 1.5 to 3 millimeters. So if we see a P wave amplitude of more than 3 mm, it is usually indicative of right atrial hypertrophy or P pulmonale. The P wave duration again is usually not more than again 3 small squares. Again 0.12 second is the usual P wave duration. So prolonged or wider P wave duration is seen with left atrial hypertrophy, which is called as P mitral. So P pulmonale represents an abnormally tall P wave, whereas P mitral represents an abnormally wide P wave. And these correspond to right atrial as well as left atrial enlargement. So here you have a baby with left atrial enlargement. You can see bifid P waves here in lead 2 as well as in, primarily in lead 2. So it is also seen in lead 1. So this is a baby with left atrial enlargement. This might be seen with conditions like mitral stenosis. Whereas if you have right atrial enlargement, you start seeing a tall P wave, and this can be seen with pulmonary arterial hypertension. Okay. The next thing that we also interpret from ECG is how the R wave progresses. So normally the R wave size increase and the S wave size decrease as we move from V1 to V6. So we see dominant S waves in the right precordial leads and dominant R waves in the left precordial leads. So this represents the dominance of the left ventricular forces. But this is not always true in newborns and in young infants where right ventricular forces can be dominant. Then we have the Q waves, which represent the septal depolarization. So normal Q waves would be usually only one small box in duration, which is 0.04 second. They are normally present in the limb leads. They are absent in V1. So Q waves, which can be seen in V1, are indicative of severe right ventricular hypertrophy as well as single ventricle or conditions like LTGA. Whereas deep Q waves in V5 and V6 are indicative of left ventricular hypertrophy or combined ventricular hypertrophy. In adults, if we see deep and wide Q waves in V5 and V6, it is indicative of myocardial infarction. The other important aspect, which is very significant for infants and newborns, where conditions like myocarditis are common, are the ST-T segment changes. So ST segment shift, either the elevation or depression from the isoelectric line, is important to be noted, as well as changes in the amplitude of the T wave. So lengthening or shortening of the ST segment duration and thus determining the QT interval can also influence the QT interval. So this is also one of the reasons why QT interval is not extremely specific for some of the conditions we discussed earlier, like long QT syndrome or short QT seen with conditions like hypercalcemia, because it is strongly influenced by the ST interval, ST segment. So up to 1 millimeter depression or elevation in the limb leads and 2 millimeter in chest leads is commonly found to occur. That is, there can be a deviation, a depression, or an elevation in the ST segment from the baseline by 1 millimeter in the limb leads and up to 2 millimeters in the chest leads. Now, J point depression is again something that is pathological. ST depression with horizontal or downward slope is also abnormal. So if you find ST segment depression, which is more than what we discussed as normal, we can see this with digitalis toxicity, with myocardial ischemia, as well as with hypokalemia, whereas ST elevation is seen with pericarditis, myocarditis, and again with myocardial infarction. So both ST elevation as well as ST depression can be seen with myocardial ischemia. Now coming to T wave, which represents the ventricular repolarization, it is positive in V1 and V2 up to 3 to 5 days of life. And between 5 days of life and adolescence, the T wave gets inverted. Again, it becomes positive in adulthood. It is positive in V6 at all ages. And the size of the T wave is best measured in the left precordial leads. So the normal norms, especially for young infants, is that in V5 and V5, the T wave is below 7 millimeters, and in V6 it must be 5 millimeters. Now, where do we see abnormalities in the T waves? If you see tall and peak T waves, tall tented T waves, it is indicative of hyperkalemia as well as left ventricular hypertrophy, usually the volume overload type, and posterior wall myocardial infarction. Whereas flat and low blunted T waves are seen with hypokalemia. They are seen in a normal newborn as well as in pericarditis and myocarditis. Inverted T waves can be seen again with pericarditis, myocarditis, and cardiomyopathy, as well as with LVH of the pressure overload type. So these are ECG images that show ST segment depression, which is abnormal depression from the baseline, particularly in the precordial leads V3 to V6. So here we see T wave inversion from V5 in V5 and V6. I think we have already discussed about ventricular hypertrophy calculation. So I'll not go into the details of this. Yeah. So in a newborn, usually T wave is upright in V1 until day 3 to 5, and by day 5, the T wave should generally become inverted or become flat. If it is still upright in V1, then the newborn should be having pathological RVH. So these are some images where you see T wave inversion in V5 and V6, which is often seen with left ventricular hypertrophy. So here we see that there is the QRS wave is there is a negative deflection in leads V1 and V2, and then we have positive deflections in V5 as well as in V6, indicative of left ventricular hypertrophy. So I think I'll stop here, and if any other points to be added by Dr. Nitin, I'll hand over to you. If there are any questions, we can take them up.
I think most of it we have, whatever we have not discussed in detail, you have covered it, and with most important clinical aspects which we see in neonatology has already been covered by you. In case there are questions, I will share them with you. And if at all there are questions here on the group, then also, yeah, there are a couple of questions, madam. How to identify P and T waves in tachycardia?
How